1 in every 4 women around the world suffer from chronic pelvic pain. That's a really frequent condition, much more frequent than many other non-communicable conditions. And it gets only 10% of budget for research and less than 15% less of budget for awareness. And that's probably because society still thinks that pain is normal, and we still blame patients for chronic pelvic pain. And we have to move away from that. I'm J.D. Villegas. I'm the director of ALGIA, the Advanced Laparoscopy and Pelvic Pain Center in Pereira, Colombia. It's my privilege, my honor to be here today. And I hope the things that we're going to be talking about are not only new, but also useful for your day-to-day practice and for your pain patients. I don't have any disclosures beside knowing that I am part of a transdisciplinary group that sees patients with chronic pelvic pain, and that I'm part of several boards and advisory boards for minimally invasive surgery and pelvic pain. And I hope that at the end of this presentation, you're going to be able to know the difference between acute and chronic pain, the role of central sensitization and transdisciplinary approach for these patients with chronic pelvic pain, and the so-called chronic overlapping pain conditions. So let's start with some definitions. Spoiler alert, FIGO is working in a kind of palm coin definition and classification for chronic pelvic pain. I hope we're going to be presenting the results maybe in July and then in South Africa, and I'm aware some of you are already involved in that project. But until we get that, we still use the ACOG definition that it was published a couple of years ago. And it says that chronic pelvic pain is the non-oncological pain that has been there for 3 to 6 months, that is located in a really big anatomical area, including the abdominal wall under the umbilicus, the pelvis and the perineum, the low back and the buttocks, and that is severe enough to cause cognitive, behavioral, sexual, and emotional consequences. One good thing about this ACOG definition is that they included the cyclical pain in the definition. So now patients with dysmenorrhea that have affected their quality of life are considered pelvic pain patients. Again, 26% of women around the world have chronic pelvic pain. Chronic pelvic pain is responsible for 40 to 60% of laparoscopies. 40% of patients never seek medical help because they think having pain is normal. 80% of patients are underserved, and only 15% of health providers say that they enjoy taking care of patients with chronic pelvic pain. And let me start with a case that probably is a case that we're going to be related with, because it's a really common case in our day-to-day practice. This is a real case. This is not a made up for this presentation. This is a real case from our center.
Hola bebé, ¿qué más pues?
Okay, this is a 41-year-old patient that has been in pain since the first menses. She has severe dysmenorrhea, 2 days pre-dysmenorrhea, deep dyspareunia, dyschezia, and 10 out of 10 pain. Her physical exam was normal in the chart, and she had a transvaginal ultrasound without any findings. So she was taken to the OR for a diagnostic laparoscopy. She had a stage 1 endo with some peritoneal lesions, and those lesions were coagulated. And after the surgery, the surgeon said, okay, you are cured and you don't need any other treatment or medication. So she went back home, but 2 years later, she was still in pain. She didn't want to get pregnant. She just wanted for the pain to go away. So she went into medical treatment with Dianogest, 2 milligrams per day. And no matter she was in amenorrhea for 8 months, she was still in pain. She had non-cyclical pain, dyspareunia, dyschezia, and lumbar pain. So she got transvaginal deep endometriosis ultrasound with adenomyosis and some nodules in the retrocervix and with lesion in the rectosigmoid. So she was concealed and then took to the OR for a TLH, bilateral salpingectomy, and a bowel resection. She got a discoid bowel resection. Everything went fine. This is the how fast do we do surgery in Colombia. I don't know if you do that here in India, but this is a regular surgery. So she got the surgery. Everything went fine. She went home 18 hours after the surgery. Nothing happened. She was asymptomatic for 7 months, but then she came back with non-cyclical pain, dyspareunia, multiple urinary symptoms, severe constipation that she didn't have before the surgery, and again, 10 out of 10 of pain. She was depressed, anxious. Now she was into opioids without an improvement and with suicidal thoughts. And this is really common. But the big problem about this patient is that the GYN after the surgery said, you know what? You don't have your uterus. Don't come back. I don't want to see you again. So your pain is in your head, and I don't have anything to offer to make you better. So remember that after surgery alone, when we're talking about endometriosis, after surgery alone, 70% of patients will have persistent pain. 1 in 4 will have new symptoms after the surgery, and 30% of patients will need a second surgery within 36 months. But why? Why they don't do better? We did this beautiful big surgery. It could have done by any of the great surgeons you have in India or in Europe or back in Latin America. We have big centers doing big surgery. But no matter who's doing the surgery, Harry Potter can be doing the surgery and patients are going to be still in pain. And why is that? Okay, these are the 3 reasons why patients don't do better. The first reason is that they still have the primary pain generator. The surgery was really hard. I was not prepared to see deep endometriosis. I didn't know how to get rid of it. This is not the case of Jennifer because she had a complete deep endosurgery. And the second cause is that patients with chronic pelvic pain do have something called chronic overlapping pain conditions. It means that they have multiple pain generators. And if you just diagnosed one, the rest of the pain generators are going to just don't let patients do better. And the third one is the central sensitization. And I'm going to be talking about this in a moment. You need to know that acute and chronic pain are completely different. As acute pain is a symptom of a tissue damage, chronic pain is a disease. And when you don't know the difference, you're going to be just prescribing analgesics, NSAIDs, opioids to patients with chronic pain without knowing that it's completely different having chronic pain than acute pain. This is a publication we have probably 3 or 4 years ago. We just characterized around 2,000 patients from our center, and this is what we got. Only 7% of patients with chronic pelvic pain have only one cause of their pain. 93% of patients with chronic pelvic pain have multiple pain generators and chronic overlapping pain conditions. And you need to have that in mind because you're not diagnosing the rest of the pain generators. Patients won't do better. And finding many overlapping pain conditions suggests a common physiopathology, but also a possible common treatment. And chronic overlapping pain conditions in GYN began probably in the early 2000s in a beautiful paper published by Maurice Chung when he was still working in Ohio in the States. And he said that patients with pain and endometriosis have between 65 to 85% of the times interstitial cystitis and bladder pain syndrome. And from there, we discussed that patients with chronic pelvic pain do have other overlapping pain conditions, including IBS, IC, lumbar pain, migraine, and so on. So why do we see patients with chronic pelvic pain that also have other pain conditions, including, as I said, vulvodynia, chronic low back pain, IC, IBS? Are these patients crazy or anxious or depressed, or they need a new surgery, or they just want to bother you? Friday, 5:30 p.m., you're ready to go home. You're really tired. You don't want to see any more patients. It's the last patient of the day. And she gets there with a history like this big, saying that, thank God I'm here because you're the only one who's going to be reviewing my entire chart and help me with my pain. Or that these painful disorders tend to cluster indicates something about these patients. Well, that's what we call central sensitization. Central sensitization is an amplification of the neural signals causing hypersensitivity and persistent pain due to anatomical and functional changes of the central nervous system that at the end causes spontaneous pain. No matter, you don't have the initial cause of the pain, you don't have the endometriosis anymore. But if we could just put Jennifer's head in a jar away from her body like they used to do in Futurama, she would be still in pain because she has central sensitization. That's really important to have in mind. And it is really easy to diagnose central sensitization. Just think about it. If you have a woman with widespread pain, other pain generators, and she's been in pain for a long time with a really bad pain, probably she has that. You can also use one of these questionnaires. We use CSI that is produced initially for fibromyalgia, but now is being validated for endometriosis. Or you could use the French index, the Convergence's pelvic pain criteria, and just look at the physical exam for allodynia, hyperalgesia, and trigger points. Patients with those items probably have central sensitization. And it has some clinical implications. The first one is that you should not promise a cure to those patients. You have to reduce their disability. These patients would respond in a different way to the regular peripheral target therapies, including OCPs and surgical treatment, and these patients are going to have more acute and chronic post-surgical pain. So we should start with the gold standard management that we already know, including hormonal therapy for cyclical pain and surgery when it's indicated. But when patient is not doing better, just look for new ideas and new diagnoses, reassess the mental health, optimize the pharmacological treatment, and also always face disability. And we're about to publish this data, but if you have a patient with endometriosis, pain syndrome, and pelvic floor dysfunction, that patient has 85% chances of having central sensitization. I have this separated slide about physical therapy, because if you see patients with chronic pelvic pain, you need a strong group of physical therapists. It is important to use physical therapy in these patients. In our center, 78% of patients would benefit from physical therapy. It improves the function, it improves the pain. You need to identify the experienced professionals in your area. Patients need to know that they're gonna get manipulation inside the vagina or the rectum, that they're gonna be worse of their pain in the first 3 to 5 sessions, but then they're gonna be much, much better. From COVID-19, we learned that these patients can be seen as a remote visit for the first time. It's really useful because you're gonna let patients just tell the story and you will decide what are the next steps before you see them face to face and do the physical exam. And you need to move away from the endometriosis era where you only had diagnostic negative laparoscopies, scar management, and surgery, and patients not doing better just needed another surgery, and move to general theories of chronic pain, chronic overlapping pain conditions, central sensitization, and transdisciplinary approach based on the biopsychosocial model. And these are the 5 gold treatments. Patients need chronic treatments, multiple visits, and multiple health providers. You need to educate not only your patients, but also the other health providers. Your colleagues need to be educated. Patients need to change the lifestyle. Remember that cure is not a goal. You need to improve disability and quality of life in these patients, and you need to build a team. Patients with chronic pelvic pain do not a solo doctor. They need a team that takes care of them. And patients need a complete evaluation before surgery and also non-surgical treatment. And this is at the end what patients need. They need surgery, but that's not even the first line of treatment. They need pharmacological management for long term. You need to take care of mental health. Diet is important. There is a lot of published data about data and chronic pain. They need anti-inflammatory diet for the constipation and the bowel, diet for the bladder, diet for the endo. They need physical therapy. Make sure you have a really strong group of physical therapists. And move beyond only surgery, address the pain as a whole, build a team. But Dita said I have 1 hour for this presentation. Okay, build a team, share your results. Maybe you're doing a lot of things that we don't know. It is really important to research and publish the results. And this is my take-home messages. Chronic pain is a diagnosis. Patients need a transdisciplinary approach. The standard therapies are not always indicated. You need to include some theories that you didn't learn in your residency program. And this is one that is really important. You never heard a patient with hypertension going to her internal medical doctor saying, okay, my blood pressure is normal. Should I just stop the medication? They don't do that. And that's the same for chronic pelvic pain. They need to know they need the medication for a long time. And you need to identify your resources to facilitate treatment.
Thank you. Thank you so much for this very, very difficult topic that you have handled so comprehensively. I think pain, where we can't sometimes understand the etiology, is really, really difficult. And multidisciplinary approach, like you just showed to us, using surgery, medical therapy, mental support, pharmacological drugs, and of course, physiotherapy, all of this together will help improve the patient's symptoms. And the biggest difficulty being to convince the patient that the therapy needs to be long-term. So thank you so much for pointing out all these important aspects. We really enjoyed the talk. Thank you.